My patient Nimar Ratna Pereira, 59 years old, father of three, is a retired officer of Ceylon Electricity Board from Maharagama, who was a diagnosed patient with the hypertension for several years. Because I took the history from the son-in-law, he didn't know any brief history.
Sir.
He didn't know, sir, that
Detailed history about his. That's fine.
He presented with the acute onset, left-sided body weakness and the speaking difficulty for 8-day duration. On 22nd of December, he had developed acute onset bilateral headache, which was a severe unbearable headache and but not associated with any stiffness or vomiting.
When was that?
22nd of December.
22nd.
And after the headache, he sat on the chair, but the headache didn't subside. And when he tried to stand up, he couldn't stand up. And he had developed a left-sided body weakness involving left upper limb and lower limb, but not associated with any mouth deviation or sensory impairment or bowel or bladder sphincter dysfunction. With that body weakness, he had developed difficulty speaking. He couldn't speak properly. Others couldn't understand what he said, but he couldn't react what others said. So after this weakness, he was admitted to the Warren Hospital. At the Warren Hospital, CT brain was done. And at the hospital, he had developed a difficulty of swallowing food and water also.
The speaking difficulty, you said he could not express himself.
Yeah, because he couldn't understand what others said, but others can't understand what he said.
What?
Others can't what he said. Others couldn't understand.
Couldn't understand what he was talking about.
Yeah, and what the patient can understand what others say.
Right. Harry.
And with the difficulty of swallowing, he didn't have any vomiting or any visual field defect. And due to this difficulty of swallowing, he was...
Now, visual field defect is not something you would comment on the history, isn't it? He didn't have any visual disturbances or visual abnormalities.
And he was fed via the NGTO. And but his concept level was normal. And so he was transferred to the NHSL on 22nd December for further management. And he was a diagnosed patient with hypertension for many years. And he was on oral medication without any good compliance or follow-up. And he didn't have any history of the diabetic mellitus or hyperlipidemia. He was a chronic smoker for many years, but he smoked more than 5 cigarettes per day. And he was a chronic alcoholic.
Pack here.
Sir, because I took the history from that son-in-law.
That's
because he also knew that patient for 1 year. He is a chronic alcoholic person and he consumes 1 bottle per 3 days. He is at 8 units per day.
8 units per day.
And he had a persistent family history of stroke also. And he didn't have a history of the myocardial infarction or any
Stroke at what age?
first
No, stroke carry check and advice.
I answer LDH.
LD. Okay.
And he didn't have an issue of myocardial infarction or any transient ischemic attacks before, and no any previous history of oral rashes or facial rashes, any suggestion of any connective tissue disorders. And after he had developed left-sided body weakness with speech difficulty and swallow difficulty, now he is completely
Bed bow.
Now the physiotherapy exercises were started, and his position is also being changed regularly, but not use any air mattresses or not apply any external stocking. But he didn't have any wet sores or any sign of DVT. Now he is being fed via the NGTU, so he is on the liquid food only. He can't sit up or stand up, and he couldn't transfer from bed to chair. And he couldn't wash face, brush teeth or change clothes. He is totally depending on other support. And after the admission, CT brain was done, and the family members were informed that he had a bleeding in the brain, and it will take long. And also they were informed that it will take more time to recover, and also they were informed about the complication and other management plan also.
Social.
daughter, wife and son-in-law. He was a former officer in Ceylon University Board. Now he is retired. His son-in-law is running a garage. He has a good family support. Previously he lived in upstairs. Now upstairs, and there is a attached bathroom also. And the road is near the house. They have a car, and nearest hospital is Gavardhanapur Hospital. And his family members have good knowledge about his current condition and the future management and communication.
Okay, thank you. Right, so the discussion now, last few weeks we have focused quite a lot on symptoms and how to analyze symptoms. So here we are doing two things now. The presenting problem here is that of, it's a body weakness, left-sided hemi weakness, and we'll discuss a little bit about that and then move on to management and management of stroke basically. Fine. Right. Now when a patient presents to you with an acute onset weakness of one side of the body, face, arm and leg, what is the first thing that comes to your mind? The patient comes with a face, arm and leg weakness. What is the first thing that comes to your mind? Stroke. That's the first thing that comes to your mind. And remember, stroke can be ischemic or hemorrhage. Right? So that's the first probable DDD that would come to your mind when a patient comes with acute onset weakness. Right. Where is Jeevna? He went out. With whom? With his friends. Where is Jeevna? Why is being kicked out of the country? 31st party. Visa. This time very close. Visa office. Hari, come on. Hari, okay. Okay, so that's the first DD that comes to your mind. Right. But also you should be aware of other possibilities that can present like a stroke. What are these? Other things that can present like a stroke, or what you call stroke mimics. What are they? Stroke mimics, or things that can present like a stroke. Right? Okay, so there one possibility is migraine. Now migraine, specifically you are thinking of something called, what is the type of migraine that you are thinking of? This can sometimes mimic strokes, it can mimic a TIA, so you have to be careful. What is it called? No, Todd's Paris. Hemiplegic migraine, yes. Hemiplegic migraine. Anybody seen patients with hemiplegic migraine? No. Martino? So hemiplegic migraine is a type of migraine where the aura is the hemiplegia. Right? So they initially get weakness of one side of the body and then they get the headache. Right, so that's a stroke mimic, where sometimes we find patients coming with recurrent episodes of weakness and we think it's a TIA, right? Recurrent TIAs, but when you go through the history you find that there is always a headache accompanying, and that's how you evaluate and try to look at the stroke mimic. So that's one possibility, and that can present with recurrent attacks of hemiplegia. Anything else? You're correct, but that's not a very common cause. Okay, so another possibility is sometimes following seizures, right? So when you have seizures, especially when you have focal seizures, you can get a sort of transient weakness, hemiplegia. That is called Todd's paresis. That's after the seizure, transient weakness. Hari. Anything else? Ashan? What sort of infection? Meningitis. Okay, so some infections, especially a sort of a focal encephalitis, you're correct in that sense. Sometimes you can get a focal encephalitis that presents with hemiparesis, right? Where the encephalitis is focal, it's involving only one area of the brain. Any other possibilities? Yeah, space occupying lesions. Space occupying lesions. Space occupying lesions can be tumors, abscesses, anything. What are the other features that you would get if it's a space occupying lesion? Yeah, so they might have features of increased intracranial pressure. Very good. So in the history, how do you get that out? Early morning means what sort of early morning? Ogolonge early morning again and 9:10 AM නෙවෙයි. What sort of early morning are we talking about? Yeah, it's generally very early in the morning. 2 AM, 3 AM. Does anybody know why that happens? Yeah, so it's related to the carbon dioxide washout that you have in the brainstem. Very good. Hari. And what are the other features of increased ICP headache? Increases with coughing and straining, and is usually associated with vomiting. Vomiting again early in the morning, they have severe vomiting. Okay, so generally space occupying lesions will have this sort of history, so headache, and then what about the weakness? How does it differ from a stroke? The chronology, how does it differ? Yeah, it's generally gradual onset unless something, there's a tumor going, nothing happening, but suddenly there's a bleed inside the tumor, then it can present acute. So that is something that you need to think of. So sometimes tumors can present even with acute neurology like this. The patient will have a background history of headache for you to suspect it, but it's going to be very acute because it has bled into the tumor. Right. So that's another that you need to mention. Right. Anything else? Which can mimic a stroke. This patient has acute hemiparesis. Yeah, so rarely hypoglycemia can also present with focal weakness. Find out how that occurs. Sounds very funny, doesn't it? Hypoglycemia is a more sort of generalized deranged state. Why should it cause focal weakness? Very interesting. You read up why that happens and tell me tomorrow. Now, it sounds very funny, and you should always think hypoglycemia is a more generalized derangement, so why should it cause focal weakness? Right? So find out the cause for that. Right. Fine. Right. So now in this patient, what are we thinking of? Sudden onset, weakness of the left side of the body, right? What? It's most likely a stroke. There are no other features to suggest any mimic or any other cause. Right. Fine. Now, when you have a stroke or acute neurological event, you have to be very clear now to localize where the problem is. So, now how would you approach that? Where do you think this patient's lesion is? Based on the history that we have listened to, where do you think the lesion is in this patient? So, to repeat what Vichakshan has said, the patient has left-sided weakness, difficulty in expressing, the other people can't understand what the head.al is talking about, right? And he cannot express himself. So, what do you think? Where is the lesion? The moment you have weakness of one side of the body, where is the lesion? Weakness of one face, arm and leg weakness, the lesion has to be where? It has to be above where? generally above the pons. That's where the facial supply is, right? So it has to be above that point. Okay. So basically you have three possible sites where you have a weakness of one side of the body. Number one, are we dealing with a brainstem problem, right? Where else could the lesion be? Yumal, where else could the lesion be? Okay, it could be in the cortex, right up there in the cerebral hemisphere. Ravindri? Yeah. The other place is somewhere in the internal capsule, because all the motor fibers are condensed in that area, packed inside that area. Hari. Okay. Okay, so where is this patient's lesion? No? Where is this patient's lesion? Why cortex? Yes. So he has clear evidence in the history to suggest higher function derangement. So cortical lesions, what you are going to find are, there is going to be a higher function disturbance, right? Higher function disturbance. So what are the things that are disturbed commonly? Higher function is the cortical lesion. You are going to have higher function derangement. Like what? Common things? Speech, yes, speech. Speech and language. Speech and language. That's if the lesion is in the dominant hemisphere. Speech and language abnormalities. Right. Anything else? Any other higher functions? Thought. It's a complicated thing, thought, isn't it? Memory again is supplied by multiple areas in your brain. There is no very specific single place that manages memory. There are objective things that you can actually check on examination, right? Ability to draw, ability to calculate, right? Then there are other things like left-right orientation, spatial orientation. Those are difficult to get in the history. That's why I just focused on the speech and language, because that's the easiest thing to get out of a history. The other ones are, you have to be very objective, it's difficult to assess sometimes. But remember that your higher functions, speech, language, you have things like drawing, calculation, recognizing left from right, performing certain tasks. For example, combing hair, right? Or sometimes you ask the patient to show how they would blow out a candle. Right? Those sort of learned tasks, they can't perform because their higher functions are not working. So it's an interesting area, it's rather confusing, but if you have time, just read about these higher functions and how you assess them. I think psychiatry will maybe do a little bit more on this when they talk about dementias and things, but for history wise, the most important thing you are looking for is a speech disturbance and maybe a language disturbance. Okay, fine. If it's in the cortex, apart from the weakness, what are the other features they will have and the higher function disturbances? They will also have sensory impairment, right? Hemisensory loss. Hemisensory loss. And sometimes these visual disturbances, right? Visual disturbances, because the optic pathways actually go through the temporal lobes, right? So they might have certain visual disturbances. Right. So that's a cerebral cortex. Then we have the brain stem. If you have brain stem problem, what are symptoms the patient will have? So the hemiparesis is due to a brain stem problem. What are symptoms that they will have? Yeah, symptoms. Vertigo, yes, vertigo, very severe vertigo. Dysphagia can occur even in these cortical lesions because the motor pathways are disrupted. But okay, dysphagia, especially dysphagia predominant to liquids. Lot of nasal regurgitation occurs in a brain stem problem. Nasal regurgitation, vertigo. What else? Prominent symptoms you get when the brain stem is involved, but this is very important. Clinically, you have to localize the site of the lesion. Sorry? That's not a very. Diplopia, yes, diplopia, drooping of the irids, diplopia. Diplopia occurs mainly in these midbrain and pontine lesions because a lot of eye movements are mediated by these centers. Anything else? The other prominent symptom that they are going to have is unsteadiness. Because if you remember your anatomy, there are a lot of cerebellar connections with the brainstem, and these are affected when you have an infarct in the brainstem. So they get a lot of ataxia is the technical term, but in the history, they have a lot of, they can't sit still, they have swaying, they can't balance themselves, right? Right. So that's if they have a brainstem lesion. Now, if it's a lesion in the internal capsule, what will happen? So cortex will have higher function disturbances, motor, sensory, visual abnormalities, everything. Brainstem will have brainstem symptoms. Internal capsule, there you have only the motor weakness because it's a very small, very localized lesion. It's like just a single point lesion. So it's usually a pure motor syndrome that they get, pure motor syndrome. Okay. So in this patient again, where is the lesion now? What side cortex? Right sided cerebral cortex. Slightly unusual because most of the time, now he has expressive speech abnormality. Most of the time the dominant hemisphere is not the right hemisphere, it is the left hemisphere, but in about 20% you can have the right hemisphere dominant also. Because the expressive aphasia, expressive speech disturbance usually occurs when you have a lesion in the dominant hemisphere, right? You are absolutely sure about this speech problem. Right, so just using the history, you can actually do quite a lot of neurological localization. Right, so now what we know so far is the patient has come to us with a sudden onset weakness of the face and arm and leg on the left side, speech difficulty, and later had swallowing difficulty also. Our main diagnosis is a stroke. We also considered stroke mimics, but we did not find anything supportive of any of that. And then based on the history, we have done an analysis to say the lesion is probably in the right cerebral cortex, right? Okay. Now what is our next step in the analysis of this patient? What is the next step in the analysis of this patient? Now we have to find the cause for the stroke. So stroke, there are two causes if you broadly think of it. What are the two causes? Ischemic versus hemorrhagic. There are two causes, so ischemic, hemorrhagic. Right. So I have gone through three steps. First of all, we have excluded the stroke mimics. Number two, we have localized the lesion, answered the question where is the lesion. Now we are trying to find out the etiology. So this is the same pattern that we have followed for most of our long cases. Hurry. Now what do we do? Ischemic, hemorrhagic. So is there any reliable way to differentiate these two clinically? ischemia from hemorrhage? Is there any reliable way to differentiate these two clinically? The answer is no. Right? So it is clinically almost impossible to differentiate ischemic from hemorrhagic. But people believe that yes, hemorrhagic stroke might present with headache. Also, hemorrhagic stroke can present with a sort of a progressive worsening of weakness. Starts acutely, but it progresses. Right. And from experience, we know that generally hemorrhagic strokes, especially when they are very severe, they come with GCS, dropping of GCS and low conscious level, right? Because it causes coning and increased intracranial pressure. Strokes can also cause that, but less commonly. So remember, somebody asked you the question from the history and examination, can you differentiate ischemic stroke from hemorrhagic stroke? The answer is no, you can't, right? But certain things might push you in that direction, but it's almost impossible to differentiate with a high degree of accuracy, right? And we don't need that anymore also, because now we have free access to CT scans, right? So both those days they had these scoring systems and checklists to differentiate ischemia from hemorrhage clinically, but nowadays we don't use them because these are unreliable, right? You can't do it. Right, here of course the patient's bystanders told Chakshan that it's ICH,
Yes,
bleeding, right? What are the common causes of bleeding into the brain? Commonest cause of bleeding into the brain is hypertension, yes, hypertension, which mainly causes bleeds into the basal ganglia region. That's by far the commonest cause of bleeding into a brain. Anything else? Milakshi? AV malformations, yes, good. AV malformations. Anticoagulants, drugs. And aneurysms. Aneurysms cause mainly subarachnoid, what you were saying? Angio displays again AV malformations, means the same thing. Okay. So these are some of the common causes of bleeding into brains. Right. Okay. Fine. What are the common causes of ischemic stroke that you need to evaluate in a history? What are they? One of the commonest causes of ischemic stroke is actually atherosclerosis. Atherosclerosis. The traditional risk factors for atherosclerosis. And the second is what you mentioned, cardioembolic. Those are the two common leading causes of stroke. Right? Cardioembolic, most common cause of cardioembolic stroke is AF, right? Right. Now, for your exams, we generally don't give young stroke patients. That's more of a sort of a postgraduate level evaluation. But in those sort of patients, you have to think of these rare things like autoimmune diseases, vasculitis, and so on. Right? But we generally don't give those sort of patients to you because it's a bit of a different level of discussion, right? But now, don't ask for SLE in this elderly man. But don't ask for that. It doesn't have any relevance in this patient. If there is a young 25-year-old female leucoma with a stroke, yes, definitely you have to ask about vasculitis and SLE and all of that. But here I don't think it's relevant at all. Right. So that's a bit of a postgraduate case. Young stroke is more of a postgraduate evaluation. Don't worry too much about that. You should know the basics Hemorrhagic stroke, common causes. Ischemic stroke, common cause. How you would ask that in the history. Right. So in our patient who came with a weakness of one side of the body, we have gone through several stages in his evaluation. Number one, we have asked about stroke mimics. We have asked about the we talked about the localization. We have gone through the etiology. Right. The last thing that you have to do is what Vichakshan has done very, very nicely, is to evaluate what happened to the patient after the stroke and especially give a detailed account of his functional status. That's very important, right? Functional status, what he can do and what he cannot do. Most of your patients will be in the ward setting, so you need to elaborate on that. What they can do and what they cannot do, and in the ward you are mainly focused on the activities of daily living. Basic activities like dressing, grooming, eating, their bodily functions, continence, basic functions you need to describe. But that's very, very important in the management of stroke, right? And Vichakshan has also asked about common complications following stroke. Aspiration. What are other common complications following stroke? Bed sores, yes. What else? Deep vein thrombosis. So make sure that you ask about them also. Okay. Right. The other thing that you should not forget in a stroke history is to give a detailed social history. What you commonly forget to do is describe the home and work environment, right? Especially the home environment. You have to focus on accessibility, right? Now, this chap was on a first floor of a building. Yeah. So that sort of thing. So that this might cause problems when you send the patient home, because all of why you are taking history and exam is not only to pass the exam here, you are basically in charge of the patient's management. So you need to find out what about accessibility, about the toilets at home, right? Their social support. All of that is essential because stroke patient needs a lot of social support, family support, needs accessibility, right? Toileting, these are a lot of issues that can arise, right? And in other parts of the world, people, and here also, when the patient is stroke, they go to the house and do modifications and all of that for them to improve their accessibility and their function. So that you need to describe in the history, otherwise we don't know. So the examiner and also the consultant on the ward round will be interested to know about that. Because once you finish your management, you are going to send the patient back home. If the patient is on the 7th floor of some building without a staircase or something, or without a lift, what is he going to do? Somebody has to carry him up. Then problems in limitations in, if there is only a pit latrine or something like that, problem. So those things you need to explore. So make sure that you get a detailed account of his living circumstances and his social support. Right. Fine. Stroke patient's examination, what are we looking for? Obviously you do a detailed neurological examination, there is no way out of it. Make sure that you look for carotid bruise. These are things that you forget to do. Make sure that you look for carotid bruise and do a detailed cardiovascular system examination. Blood pressure, pulse, detailed examination. Because we don't want you to be safe and because we have given plenty of patients most of the time stroke with AF, medical students miss the AF. Where patient doesn't know, you have to get that during the examination. So make sure that you focus a little bit on the pulse, make sure that the patient is not in AF, and make sure that you examine the carotid swab bruise. Those two you commonly forget to do, that's why I am telling. Generally you have to do the rest of the examination also, but make sure that you remember to do those two things.
So why do we look at carotid bruise?
Carotid bruise are good indicators of atherosclerosis, right? Carotid narrowing. Because usually the plaque is in the carotid, which ruptures and then gives rise to small clots which shoot up into the middle cerebral arteries. So it's very important to look for carotid bridge, but that's a good indication of whether there is narrowing or not. Okay. So final conclusion for this patient is patient with poor control of hypertension with a ICH, right, that presents with a, and is a smoke also, presenting with a stroke. Right. Any questions up to now?
So smoking and alcohol can they be included to the setting? Still the person?
If you like, yes, that's fine. That's fine.
That is that family sitting also can be.
Yeah, family history. Now this is of course an elderly person. It just might not be relevant. If it's a young person who had a stroke in the family, that might be relevant. හරි මොකද්ද මధుමාදර ගන්න පණින්න හදනවද? කාට සීතල? සසංගඩ? චතුරිට? ඉස්සෙකුම? හරි. හරිද? Any questions up to now? Is it usually? It can අමාරුයි. Can be unilateral also. Relieved mat නෙවෙයි ඒක. Yeah, people tell that, but you can relieve with vomiting, and anyway when the patient vomits, of course it will get worse because you are straining, but maybe after the vomiting it, I don't know. Some people say that මේ වමන කරාට පස්සේ ඔලුව කැක්කුම අඩු වුණා කියලා කියනවා, but I don't know the explanation for that. During the process of vomiting it has to get worse because you are straining. Right. Okay. Right, so we talk a little bit about the management of stroke in a very simple way, not details. Right, so how do you manage stroke? If you are the house officer when this patient came, what are you going to do? Kiyom bala? Supun කියන්න බෑ. Right, so Supun is correct, but yeah, that's a very important point. You need to know actually quite early on whether it's ischemic or hemorrhagic. That's a critical thing in the management, because you can't actually manage a stroke without knowing that. But of course, just before that, there are certain basic things that you do, right? Especially if it's a large, massive infarct or a large hemorrhage is causing some midline shift or something like that, or it's a brainstem problem, they might come unconscious. So if the patient is unconscious, be careful, because they might have problems in maintaining their airway, the airway might be compromised. So those sort of patients, you need to be a little bit more careful. Proper BCD assessment is important, right? Especially when the patient is unconscious, because they might have problems in maintaining their airway, it might get obstructed, problem. Anywhere where the GCS is less than 10, be careful about their airway. But otherwise you don't have to do airway maneuvers in patients who have a GCS of 15, right? Remember, stroke, the GCS can be a little bit dodgy to interpret, because the speech might be abnormal because of stroke, not because of coning, right? So you have to take it patient to patient basis, right? Don't say GCS nahi patient hondata ඇස් දෙක අරගන්න because speech is not there. Don't say GCS is 10, but you say it's 10, but given the fact that the stroke is affecting the speech also. Right. So be careful of that. Another thing that you have to be very careful of is the blood sugar. Okay, that's very important, because if there is hypoglycemia, that's disastrous. If you get a stroke and the patient is hypoglycemic, That's a disastrous situation because you know that glucose is essential for neuronal metabolism. And if there is no glucose, you are in trouble. So certain basic things are needed. Basic things, basic assessment, sugar measurement, all those are important. Right? But Supun is absolutely correct because you have to know whether it's ischemia or hemorrhage early on. Otherwise you can't even think of managing. So how do you do that? You have to get a non-contrast CT brain. There is no other way that you can differentiate ischemia from hemorrhage. As I just told you a few minutes ago, clinically it's impossible to differentiate. You need to do a CT. So if you are in a very rural hospital somewhere, you will have to transfer the patient for CT. You can't manage the patient without doing a CT. So that's become an essential investigation now. Right. Okay. Right. So you do the CT. There is a big hemorrhage. What do you do? What do you do? ICH. And nothing much you can really do, but what? There are certain indications for surgery, right? Especially if it's large and causing midline shift, right? That sort of indication, refer to the surgeon, neurosurgeon. But don't refer the neurosurgeon these small internal capsules, small hemorrhages, they can't do anything about them. Only refer if it's a large hemorrhage causing midline shift or the hemorrhage is in the posterior fossa. Why? Why are you worried about this posterior fossa, cerebellar hemorrhages and things like that? Because it's a very small compartment and it can cause hydrocephalus, acute hydrocephalus. So those sort of patients you would refer to a neurosurgeon. Other patients don't waste the neurosurgeon's time. Right. Okay. Fine. So that's one thing that you would do. Another thing that you might do is if the bleeding is due to some coagulation derangement, for example, the patient has been on warfarin, then you correct the coagulation. Correct the coagulation. But you have seen this bad habit of these neurosurgeons giving vitamin K and tranexamic acid and FFP to all patients with ICH. You have seen that happening? Surgical wards you have not seen ICH, even no old medical appointments. The moment they see that tranexamic acid, vitamin K, FFP, that doesn't make any difference. So don't waste your time in giving vitamin K and FFP and all this rubbish. The patient is having a hypertensive ICH. There is no point. Doesn't work. Obviously, there is no way it can work. Right? So reverse coagulation. If the patient has a coagulation related bleed, obviously if the patient is on warfarin and has ICH, you have to give FFP or vitamin K. Right? So don't give unnecessary medication. Right. Fine. Third thing I want to tell you about ICH is that what about blood pressure control? Right. What about blood pressure control? Do you need to have a strict blood pressure control? Do you need to drop the blood pressure? Can you let it remain like that? That's why ischemic stroke. Actually, you have to do some reading. Tell me tomorrow, in a hemorrhagic stroke, should you lower the blood pressure? Right now, you will have to read some evidence to answer that question. You have to know how to read literature and find answers for clinical problems. So the clinical problem is you have ICH, patient has high blood pressure. Do you control the blood pressure or not? And you tell me evidence. You can argue, we can have a debate also if you like. So some people can say lower blood pressure. You have to tell evidence for that, right? And find out. Very interesting, very controversial field. Find out, there are a lot of clinical trials which have happened. So we need to find out what exactly we need to do. Do you need to lower the blood pressure? Or can you just let it? Are there risks in lowering the blood pressure? Or doesn't it make a difference? Sometimes you might find when you read blood pressure, there is no difference, right? Or sometimes rapid lowering of the blood pressure might cause more harm. So find out, right? So read and find out. How do you manage blood pressure in ICH? And don't be surprised, you will probably read, the conclusion will be that we don't know, but just find out what exactly is there, what exactly is around. So that's how you manage a ICH. So main priorities for ICH management as a house officer would be initial stabilization, getting the CT done, referring to the neurosurgeon when appropriate. Don't do all the ICH, don't refer to the neurosurgeon, just the large ones, midline shift, coning, posterior part of the brain ICH, those sort of things we would refer. But otherwise just forget about it, don't refer. Okay. What about ischemic stroke? What would you do then? Now, to diagnose ischemic stroke, you need not have a positive CT. CT එකේ මුකුත් නැති වෙන්න පුළුවන්. So it's all clinical. Even with a normal CT, you would still manage as a ischemic. So don't go with the opinion that you need to say infarct on the CT to diagnose a cerebral ischemic stroke. Your main idea of doing a CT is not to diagnose an infarct. It is to diagnose hemorrhage, right? So remember that you can still diagnose an infarct with a normal CT, provided your clinical assessment is done, right? So clinically you think it's a stroke, CT might even be normal. Right. What are the early features of an infarct on the CT? Early features of an infarct on a CT. Before you see the infarct, are there things that occur? Yeah. So that you have to find out what that is. Hyperdense MCA sign. Look at a picture of that on Google. Hyperdense MCA sign. What that is. And sometimes can be a very important thing. One of the early features of infarct.
There was a patient.
Then?
When we were in the Pingalore,
Can't remember. Hyperdense MCA sign කියන්නේ මොකක්ද? හරි. So what do you do? Cerebral infarct. මොකද කරන්නේ? How do you manage? We just do the principles and stop for today because it's too much otherwise. මොනවද කරන්න පුළුවන්? What can you do? Right. So now we have several options. One is you can do thrombolysis. That's an option. For a cerebral infarct or ischemic stroke, you can thrombolize a patient. Have you seen this being done? Thrombolysis. Drug that we use is generally altiplase. You had done a neurology appointment. If I didn't, you go to these wards also. They were regular shape. Stroke unit again. We give these now. Can you give thrombolysis to every patient with a stroke? Can or can't? Can't. Obviously you can't. So what sort of patients would you give thrombolysis to? One important thing is a time. Time from onset of symptoms. What is the time from onset of symptoms? Maximum is 4.5 hours. Ideally 3 hours. Right? Maximum is about 4.5 hours. From the onset of symptoms, remember. Right. Patient goes to sleep at 8 o'clock, wakes up with weakness at 6:30 in the morning. Can you thrombolize? Comes to hospital at 7:30. No, you can't. So in that the time is taken. Last time the patient was seen well. So remember, so it has to be onset of symptoms clearly defined. Age, okay, so we don't give people less than 18 years, and very elderly patients also, it's a relative problem, okay, but there are more things than that you need to look at. Size, no. Size in some cases, but sugar the infarct, not the size, but the effect should be there. Now, size you might not see in the CT, in the initial CT. What you are going by is the neurological impact of the stroke, right? What is the effect on the neurology? Then, is there a way of assessing that? Is there a way of assessing what the impact of the stroke? What is that? Yeah, there is a score which all of you have to go and read now, called the NIHS score. That gives you a score for the neurological impact. NIHS. It's a National Institute of Health stroke scale developed in America, right? That gives you the impact of the stroke. It gives you a score, right? And only if that is above a certain number that the patient qualifies for thrombolysis. So minor strokes you don't thrombolize, right? It's only the severe ones. Severe ones they will give you a value, cut-off value. So, in order to thrombolize a patient, time should be correct, right? The patient should come within the appropriate time. Number 2, the patient should have a good NIHS score. Can't be very low. You are not going to thrombolize. So, you can find out what the number is also. There is a particular number above which you thrombolize. So, minor strokes we don't thrombolize. Is there anything else that you consider? Remember that this neurological deficit should not rapidly improve. Now, some people come to hospital with a NIHS score of about 20-22, right? It's marked out of 30, 20-22 with a Renault. But now, thrombolysis එක patient then improvement එකක් තියෙනවා. So now the NIH score is about 10. So if the neurological deficit is rapidly improving, again no thrombolysis. But that might be a TIA. Because there is no way of saying no within 3.5 hours, 4.5 hours you can't say it's a TIA or not. So when the patient comes to hospital, if the neurological impact is or the neurological disability is improving rapidly, again you don't thrombolize. So time should be okay, there should be a significant neurological deficit, and that neurological deficit should be static or progressive, not improving. Okay. So those are the inclusion criteria for thrombolysis. But there are a whole lot of exclusion criteria also, right? And that you have to go and read. Lot of exclusion criteria. Common things, bleeding, arakai mekai. Somebody mentioned size of the infarct, that's also there. If it's a very large infarct also you don't thrombolize. So contraindications you need to read. Okay. Now what you need, so we stop there. There is a little bit more to discuss. Now what you need to do is, now before you go, now ගෙදර ගිහිල්ලා හරි කමන්නේ දැන් අද patient ටිකක් ඉන්නවා බලන්න, I'll tell you what. You have to now sit down and think. Say you are the house officer, right? Patient comes a stroke within this particular period of time. You have to have a checklist of what you are going to do and how you are going to get that done within the shortest time possible. Now when you go through the contraindication, there is a certain blood test that you need to send. So eva monada, right? Because if you are not ready to do that, you will definitely miss the time. But remember, 4.5 hours is just mehema karana, while patient usually has a stroke at about 8 o'clock in the morning, then enna vidyak natuwa gedara will wait for about 1.5 hours. People will stay until it honda enawada kiyala balanni. So generally the patient comes to hospital at around 3 hours or something from the stroke. Then you have only 1.5 hours to get a lot of things done, including CT scan, certain blood tests, right? So you need to time all of this and have a checklist on how you would approach a stroke patient, right? And how to get it done within the shortest period of time. What blood tests you need to send. For example, you need to look at a platelet count and a PTINR before thrombolizing. You will find a lot of those are the contraindications. So I want you to do that. Hari. Is there any new therapy now for stroke apart from thrombolysis? Yeah, there is something called thrombectomy. Thrombectomy කියන්නේ it's something parallel to what you do in cardiology. Acute coronary syndrome stent දානවා කියලා කරන්නේ. ඒ වගේ you go through a minimally invasive approach, go up to the clot and you pull it out, right? Aspirate it. It's very expensive, but people are doing it in some centers because that allows you, it gives you a better outcome in certain patients, and you can actually do that up to about 6 hours from onset of stroke. So it's increasing the time window, but here it's not practical because it's very, very expensive. That aspirating gadget, I think, is costs several lakhs, right? So it's not freely available. But remember, as medical students, you need to know that there is something like that available, right? Right? And there are a lot of interesting developments in stroke. People are now looking very carefully at this time period, time window, 4.5 hours. Now the problem is that most people, you won't be able to do the thrombolysis within that period. So people are trying to look at ways to try to increase that time window, right? So if you are interested, there are a lot of studies that came out last year that uses a lot of funny MRIs to exactly say the infarct size and the blood supply and everything to decide whether there is a point in reperfusing. So some people have shown MRI, okay, this is a bit advanced, but it's interesting. MRI, there is special MRI that you do, and that shows how much is actually dead, how much tissue is actually dead. So now people are saying that it's not the time, it's the amount of tissue that is salvageable that should be used. So they do the MRI and see there is a lot of tissue that is salvageable, and the patient time is not important anymore. So if there's a lot of, if the patient comes 12 hours later, if there is some tissue that is salvageable, you still thrombolyze. So that's a current trend. A lot of trials are happening in that direction now. Looking at imaging to see then brain එකේ salvageable neurons තියනවාද කියලා, or cerebral tissue. So it's rapidly developing, it's a rapidly developing field. Hari, so that's enough for today. There are some other things that we need to discuss, but stroke, basically what you need to know at your level is who can you thrombolyze, and as a house officer, how would you set about preparing a patient for thrombolysis. Now from what I've taught you, you know that you need to know the NIH score. You don't need to by heart it, but put it on your phones. There are lots of apps out there that give you the NIH score. You can just tap it and fill it. So when you become house officer, you need to carry that, right? What else do you need to do? How would you get the CT scan done? How would you get the blood tests done? What blood test do you need? That we are going to ask you at the exam, because that is very important. But if you don't know that, you won't be able to get that time window. Right. Right. Any questions? So a lot of homework to do. The blood pressure control you have to tell definitely. Yeah? You have to find out and tell me tomorrow. Sorry. Okay. Now there are lots of interesting patients in the female ward which you have to see before you go now. There female ward point I taught. Show the other people and let them see bed 44. You can do the same thing I did in the morning, see if anybody. So there is a challenge. You have to auscultate and tell the diagnosis. If you tell the diagnosis, you get a chocolate, otherwise you don't. Female ward people didn't get the chocolate, so the male ward people can try to get the chocolate. But you have to do it in the same way, no? So that's bed 44. Then there is another interesting patient in bed 35. There is a young patient with multiple fractures. You remember that there was a patient a few weeks ago also, young patient with backache and multiple fractures, ended up having a myeloma. There is a similar patient. Skull has lytic lesions. So have a look at that, very important. Put it on your group also. Multiple lytic lesions, the skull X-ray. ඒවා බලන්න. So නිකන් වාතය වෙන්නේ නැතුව you have to look at these things before you go. Yeah. So two cardiovascular patients, one is bed 44, the other one is bed 35, you have to see. There is another patient in bed 5. වාගේ the patient. If she is in a good mood, she will allow you to examine. Not in a good mood. Try and see. She has very good physical signs. If you can just try to convince her to let you examine. Right. She's one of our frequent customers. Amadam wage enawa, you might have seen her before. If yeah, it all depends on. So sometimes we find that they come within the proper time, we keep them here. Ayawala they can't thrombolize. Thrombolisis is only available in main hospitals. NHSL, Ragama, Kalubovila, Kalutara තියෙනවා මම හිතන්නේ. කලුතර, අනුරාධපුර, ගෝල් ඒ වගේ පේරාදෙනිය, කැන්ඩි ඒ වගේ මේන් සෙන්ටර්ස් වල විතරයි තියෙන්නේ. හරි. දැන් බින්දම රතින් ජපත් කරනවා. Hari. So have a look at those patients and then go and enjoy your 31st night or whatever. Jeevnath is already enjoying his 31st night.